Sunday morning in StAMPSville, a 24-year-old woman is carried into the emergency department by her sisters. She is pale, sweating and holding her right lower abdomen. Her pulse is 118.
D-83. Foundation phase. Lower abdominal pain in a young woman is the classic StAMPS opening, and it is where hidden emergencies live. Before anything else, what is your first investigation?
A pregnancy test. Urine human chorionic gonadotropin at the door, before she even leaves the triage bay. Every woman of reproductive age with lower abdominal pain gets one, no exceptions.
And if that test is positive, what does the pain pattern tell you?
Her pain is out of all proportion to her bleeding. That combination, severe pain with little or no vaginal bleeding and a positive test, points hard at ectopic pregnancy. When bleeding dominates and pain is mild, an intrauterine problem is more likely.
Say the dangerous sentence out loud.
A positive pregnancy test with pelvic pain is an ectopic pregnancy until an intrauterine pregnancy is proven, and half of women with an ectopic have no risk factor at all, so a clean history protects nobody.
Still, the history is not decoration. What do you ask in 90 seconds?
Last menstrual period, and was it normal or just spotting? Because ectopic bleeding often masquerades as a light period, previous ectopic or tubal surgery, pelvic infection or chlamydia in the past, any coil in situ, fertility treatment, which also raises heterotopic risk, a tubal pregnancy coexisting with a pregnancy inside the uterus, smoking, and dizziness or shoulder tip pain.
Give me the numbers that matter in her first 10 minutes.
Pulse 118, blood pressure 90/60, respiratory rate 24. She is cool and pale. In a young woman that is compensated shock, and I treat the tachycardia as the alarm, not the blood pressure.
Because young women do what?
They compensate until they collapse. Blood pressure is a late sign. By the time she is hypotensive, she has lost a substantial volume. Rising heart rate with worsening pain is my escalation trigger.
What does shoulder tip pain mean here?
Referred pain from diaphragmatic irritation by blood in the peritoneum, hemoperitoneum until proven otherwise. If she mentions it, my concern for rupture goes up sharply.
Actions. In order, with the drug, the dose, and who does it.
2 large bore cannulas, 1 for each arm. Take bloods for group and hold in crossmatch. Saline bolus, a liter, running now. The nurse gets the crossmatch while I examine. Another nurse calls the regional gynecologist and aeromedical in parallel.
You just delegated 3 tasks in one breath. Name the people.
Sarah, the senior nurse, owns the bloods and the crossmatch. Tom, the second nurse, owns the telephone, the gynecologist, then the aircraft. I own the patient, the cannulas, the examination, and the decisions. In a hospital with no resident medical officers, that sentence structure, who owns what, is the whole management plan.
Blood products in StAMPSville, what have you actually got?
4 units of O-negative packed cells in the fridge, and nothing else refrigerated. That is my ceiling. If she is bleeding through them, the answer is theater, not transfusion.
And you're sonographer on a Sunday?
At home, part-time, weekday service only. Formal transvaginal ultrasound does not exist for me today. I have a portable machine at the bedside and my own hands.
So what do you do with the probe?
A focused scan. Free fluid in the pouch of Douglas alongside a positive test, and this picture is enough. I am not confirming an adnexal mass. I am answering one question. Is there blood where blood should not be?
There is. Dark free fluid and the uterus looks empty. Now what?
That is a ruptured ectopic until someone proves otherwise. I call the GP anesthetist and the GP surgeon at home, and I activate the theater. 2 operating theaters exist in this town, and today one is hers.
And when the weekday sonographer does scan a stable woman, what are you hoping they will describe on the report?
The college guideline lists the reliable signs: an adnexal mass containing a gestational sac, with or without a yolk sac or fetal pole, or an empty sac with a ring shape they call the bagel sign, or an inhomogeneous mass, the blob sign, that does not slide away from the ovary when pressed. Any of those with a positive test is diagnostic.
And a scan report that says, unremarkable uterus, no adnexal lesion. In a woman with a positive test and pain, is she reassured?
No. Ultrasound is inconclusive in up to a third of women, and skill varies. A normal-looking scan with a positive test and pain is a pregnancy of unknown location with a red flag attached, not a discharge. She gets the 48-hour protocol or a transfer and explicit safety netting on the way out.
Retrieval is 90 minutes away, by fixed wing. Why not just call the aircraft?
Because she may not have 90 minutes. A ruptured ectopic can bleed out faster than a plane can fly. The aircraft is part of the plan, but for a hemodynamically unstable rupture in a town with a theater, the theater is faster.
So what is the aircraft for?
For the stable ones. And for post-operative transfer, because this town has no gynecologist, no intensive care, and no blood bank beyond those 4 units. She will wake up here perhaps and recover there.
Walk me through the resuscitation while the team dries in.
Keep her warm, head down, oxygen if hypoxic, and treat pain. Morphine 5 mg intravenously, titrated, with an antiemetic. Analgesia never obscures a surgical abdomen enough to matter, and a woman in agony gives you a worse examination.
While the theater team scrubs, what is the anesthetist's concern in a bleeding woman?
Induction drops the pressure. She is hypovolemic, so the anesthetist wants volume on board, blood running, and vasopressors drawn up before any drug pushes her over the edge. That is exactly why the resuscitation never pauses for the theater call. Both tracks run at once, and I say that sentence to the examiner deliberately.
Consent and communication. She is frightened, her sisters are in the corridor.
I tell her plainly, the pregnancy is in the wrong place, it is bleeding, and I need to operate now to stop the bleeding and keep her safe. I ask what she understands, what she wants her sisters to know, and who else should be called.
Her sisters are Aboriginal women, in a town where hospital means stories. How does culture shape this conversation?
I ask, I do not assume. Some families want everything everything said plainly to everyone. Others want information to move through an auntie or the eldest sister, and shame around pregnancy loss is real. Our Aboriginal health worker and the liaison officer are part of the team today, not an afterthought. And if a female clinician can hold her hand in theater, I organize that before she goes through the doors.
And the woman herself is the decision maker. Say that carefully.
Always. I invite family into the discussion because she wants them there, but consent is hers alone unless she is unconscious. When she is too shocked to consent, I act in her best interest under emergency doctrine and document exactly that reasoning, and I keep explaining to her family what is happening and why, every step.
While the theater warms up, what happens at the bedside, minute by minute?
Observations every 5 minutes, pulse pressure, respiratory rate, conscious state, owned by name, a catheter and a fluid chart. The bloods run through the point of care machine, hemoglobin, biochemistry, and a blood gas, which tells me if she is compensating with a metabolic acidosis. The O negative is physically in the room, checked and warm.
Now flip the clock back. She walked in stable, pulse 80, pain moderate. Does your pathway change?
It changes shape, but not its spine. The pregnancy test still comes first. Then I want an ultrasound, a quantitative beta HCG, a blood group and antibody screen, full blood count and group and hold. Same parallel structure, calmer pace.
The quantitative HCG in StAMPSville. Practically, when do you get it?
Our point of care machines do biochemistry and blood gas, but not a formal quantitative HCG, and the couriered laboratory runs 3 times a week, so the number I can chase today is limited. What I can always get is serial levels arranged before she leaves.
And if the scan shows an empty uterus with a HCG above the discriminatory zone, what is that zone?
Around 1500 units per liter for transvaginal ultrasound. Above that level, a healthy intrauterine pregnancy should show a sac. Empty uterus above the zone with pain means ectopic is likely, though a multiple pregnancy can still confound it.
Below 1500, scan shows nothing anywhere. What is that called and what happens?
A pregnancy of unknown location. She is not diagnosed and not discharged. The protocol is repeat ultrasound and repeat HCG at 48 hours. A rise above 63% suggests a viable intrauterine pregnancy. A fall suggests a failing pregnancy. A slow rise or plateau is ectopic territory.
Where does she spend those 48 hours, 300 kilometers from the sonographer?
That is the real rural decision. If she is reliable, asymptomatic, can stay near the hospital or with family in town, and I can guarantee the repeat blood draw, she may wait locally. If she cannot, she transfers for an early pregnancy assessment service. The plan is written down before she leaves, with a named owner.
Now she is stable. The scan shows a 2 centimeter adnexal mass with no fetal heart, HCG 2200. The gynecologist offers medical management. What drug, what dose, what route?
Methotrexate. Under the current college guideline, a level under 3000 with a mass under 20 millimeters means 1 dose of systemic methotrexate, intramuscular. Australian protocols dose it at 50 milligrams per square meter of body surface area.
And if her HCG was 3800?
Then between 3 and 5000, or a mass 20 to 35 millimeters, the guideline offers 2 doses, 4 to 7 days apart, with a warning that transient side effects like nausea and mouth ulcers are more common.
Who is not allowed methotrexate?
The unstable, the heavily bleeding, anyone with significant pain, cardiac activity in the tube, a mass over 35 millimeters, impaired kidneys, liver or marrow, breastfeeding women, and anyone who cannot reliably return for follow-up. That last clause matters most in my town.
Why does distance disqualify her?
Because methotrexate is only safe with serial HCG checks, day 4, day 7, then weekly until negative. If she lives 200 kilometers down a floodplain road and may not come back, that follow-up is fiction. Surgery or transfer beats a beautiful plan she cannot complete.
Walk me through those follow-up numbers.
Bloods at day 4 and day 7. The day 7 level should have fallen at least 15% from day 4. If it has not, I repeat at day 10, and if the fall from baseline is under 20%, she needs a second dose or surgery, then weekly until the level is negative. Missing a single blood draw is how a stable ectopic becomes a ruptured one.
What must she be told before she leaves with methotrexate on board?
Report worsening pain immediately, because separation pain around day 2 to 3 can mask rupture. No folate supplements, no pregnancy for 3 months, use reliable contraception, limit sun exposure and expect weekly blood tests for weeks, and she flushes the toilet twice with the lid down for a week.
Her blood group comes back rhesus negative. What did you forget?
Anti-D. An ectopic is a sensitizing event. The National Blood Authority guideline says 250 units intramuscularly for a rhesus negative woman in the first 12 weeks. I check she has no preformed antibodies, then give it.
Where is that anti-D right now?
Not in my fridge. Only O negative cells are stocked here, no immunoglobulin products. So it is another item the regional hospital must supply, which means another reason the transfer conversation starts early, not after everything else is tidy.
Suppose she is unstable again. Theater is running, but the aircraft is grounded by fire weather. August is grassland fire season.
Then the theater pathway is not the fallback, it is the plan. My GP surgeon opens the abdomen if laparoscopy is not available. The anesthetist runs the resuscitation, and the regional gynecologist is on video if the signal holds. We document the constraint, not just the choice.
If surgery finds the tube destroyed, what operation does she have?
Salpingectomy, removal of the tube, is the default. If the other tube is damaged and fertility matters, salpingotomy preserves it, but up to 1 in 5 of those women needs methotrexate or more surgery afterwards, with weekly HCG until negative. After salpingectomy, a urine pregnancy test at 3 weeks.
Last question on this thread. Her sister asks whether the pregnancy could have been saved, and whether she will still have children.
I answer honestly and gently. The pregnancy could not continue wherever it implanted outside the uterus, and nothing she did caused this. Most women who have had an ectopic do conceive again, though the risk of another ectopic rises. I arrange a follow-up conversation, not just a discharge letter.
There is a quieter version of this morning though. Same woman, mild pain, negative pregnancy test. What climbs your list now?
Three diagnoses jump the queue. Ovarian torsion, because it steals an ovary by the hour. Pelvic inflammatory disease, because it silently costs fertility. And appendicitis, because it kills the young and fit.
Torsion, first. What does her story sound like?
Sudden severe one-sided pain with nausea and vomiting, often in a woman with a known cyst. The classic trap is the woman who has had this pain before and it's settled. That is intermittent torsion, twisting and untwisting, and it is still an emergency.
You have your bedside probe on her. What are you hoping to see, and what will not reassure you?
An enlarged ovary, sometimes with peripherally arranged follicles, often free fluid. What will never reassure me is normal Doppler flow. The ovary has a dual blood supply and torsion is often intermittent, so a normal Doppler does not exclude it. Only surgery truly excludes it.
And the timing evidence?
The observational studies suggest ovaries distorted within roughly 8 hours do best. Time is ovary. So in StAMPSville, suspicion plus a mass is a theater conversation immediately, with the aircraft informed in parallel.
What does the surgeon do with a black engorged ovary?
Detort and leave it, almost always. Visual assessment of viability is unreliable, and ovaries that look dead frequently recover function. Ovarectomy is reserved for the truly necrotic or malignant looking. That Victorian audit showed nearly half the removed ovaries had no confirmed ischemia.
Now the second diagnosis. She is a febrile, cervix tender on movement, pain bilateral and grinding for a week. What is your minimum criterion for pelvic inflammatory disease?
Cervical motion tenderness or adnexal tenderness on bimanual examination with lower abdominal pain in a woman at risk of sexually transmitted infection. That minimum is enough to treat. I do not wait for swabs.
Why not wait?
Because every day of delay raises the risk of tubal scarring, chronic pain, ectopic pregnancy, and infertility. Rapid response to treatment is itself diagnostic. I examine, I swab, and I prescribe in the same visit.
The regimen, drug, dose, route, duration. Outpatient?
Ceftriaxone, 500 mg intramuscularly with lignocaine, or intravenously as a single dose, plus doxycycline, 100 mg orally twice a day for 14 days, plus metronidazole, 400 mg orally twice a day for 14 days.
She vomits on doxycycline. Alternative?
Azithromycin, 1 gram orally as a single dose, repeated 1 week later alongside the ceftriaxone and metronidazole. Same substitution in pregnancy and breastfeeding, where doxycycline is off the table.
When does she come into hospital?
Severe illness or high fever, vomiting and unable to take tablets, suspected tubo-ovarian abscess, pregnancy, when appendicitis cannot be excluded, failure of outpatient treatment, or when follow-up is impossible. In my town that last one catches a lot of women.
She takes the tablets faithfully, but the pain persists at her 72-hour phone review. What then?
She comes back in. Failure to respond within 2 to 3 days means I reconsider the diagnosis, consider a tubo-ovarian abscess, reconsider appendicitis, and if she has a coil in place, the guideline says consider removing it at that point, balanced against pregnancy risk, with emergency contraception discussed, and if her swabs grow mycoplasma genitalium, the plot changes again.
Say exactly how.
Mycoplasma genitalium is rapidly acquiring macrolide resistance, so blindly adding azithromycin courses is how we breed it. Resistance-guided therapy means testing for macrolide resistance markers where available, and for pelvic inflammatory disease caused by it, the recommended agent is moxifloxacin 400 mg daily for 14 days, usually with specialist advice. That is a genuinely modern answer the examiner may not expect every candidate to have.
Inpatient regimen?
Ceftriaxone 2 grams intravenously daily, or cefotaxime 2 grams 3 times a day, plus azithromycin 500 mg daily, plus metronidazole 500 mg twice a day, all intravenous.
Her swabs return chlamydia. What obligations attach to that result?
3 layers: notification, partner treatment, and retesting. Chlamydia is a routine notifiable condition. In Victoria, the doctor notifies the department in writing within 5 days, using only the name code, the first 2 letters of the surname and first name, to protect confidentiality.
Partner management, and be honest about the small town problem.
Current partners are tested and treated on the same day, doxycycline 100 twice daily for 7 days, without waiting for their results. No sex until both are treated. And in a town of 4,000 where everybody knows everybody, patient-initiated notification may be unsafe, so I offer provider referral where the service contacts partners without naming her.
Retest timing?
Around 3 months, because reinfection is common, and any new partner restarts the clock. I book it before she leaves, and our Aboriginal health worker often becomes the person who actually makes that review happen in community.
Why is she, a young Aboriginal woman, at higher risk in this district in the first place?
Not biology, circumstance. Remote communities carry higher sexually transmitted infection prevalence, and screening coverage is the counterweight. Annual testing for young people is recommended in the National Guide, and every presentation like this is a screening opportunity. I offer the full bundle: chlamydia, gonorrhea, mycoplasma, trichomonas, HIV, syphilis, hepatitis B.
A 16-year-old comes to your clinic with similar pain, scared her mother will find out. Can you keep her confidence?
If she is mature enough to understand the assessment and its consequences, she consents to her own care and her confidentiality holds. The same principle that applies across Australia. The limits are serious harm and sexual abuse. Sex involving a child under 16 or a young person with someone in authority over them goes to child protection, and in Victoria that is a statutory duty. A consensual relationship between 16-year-olds is not a report, and I keep her trust while keeping those lines bright.
Trichomonas. Would a metro doctor routinely test for it?
Often not, but in high-prevalence remote settings it is standard, and it is a common cause of discharge and pain that metronidazole covers. This is a genuine remote metro difference the examiner may probe.
Third diagnosis. The pain migrated from her navel to the right lower quadrant, anorexia, and she's rolling in the bed. Appendicitis. What is your pathway without a scanner?
Clinical scoring supports me, but the decision is surgical. I examine carefully, look for the classic signs, and I get the regional surgeon on video while she is still on the table in front of me. Bedside ultrasound for a non-compressible appendix is operator dependent, but a focused look costs nothing.
And if she is pregnant with right lower quadrant pain, Does appendicitis leave the list?
It rises. Appendicitis is the commonest non-obstetric surgical emergency in pregnancy. The appendix is pushed higher by the uterus, the signs are blunted, and delayed surgery risks both lives, so pregnancy never removes appendicitis from the differential. It makes the surgical phone call earlier and the urgency greater.
The surgeon says, start antibiotics and transfer in the morning. Your response?
I accept antibiotic first management only with a named surgical plan, a documented time of review, and escalation triggers. Antibiotics plus hope is not a plan. If her pulse rises or pain localizes overnight, the conversation reopens immediately, and I say so on the record.
The boring diagnosis that still matters. Burning urination. Suprapubic ache. No systemic features. First-line antibiotic now?
Nitrofurantoin, 100 mg orally, 4 times a day, for 5 days. Since the March 2025 antibiotic guideline overhaul, it is first line for acute cystitis, because trimethoprim resistance in E. coli has passed the comfort threshold. Trimethoprim has dropped to third line.
And the same woman but pregnant, with the same burning. Does the answer change?
Completely. Nitrofurantoin is avoided at term, and the choices in pregnancy are a cephalosporin like cephalexin, with trimethoprim off the table in the first trimester because it is a folate antagonist. And a urine infection in pregnancy is never just cystitis. It gets a culture sent and a follow-up test of cure, because untreated bacteriuria in pregnancy climbs towards pyelonephritis and preterm birth.
And if this were pyelonephritis with fever and flank pain?
That is admission here, intravenous antibiotics guided by the current antibiotic guidelines, and a retrieval conversation if she is septic. Urinary infection does not get to be the afterthought that kills someone.
Last thread. Period pain that has always been called normal. What do you say to a young woman who has been told to just take naproxenic?
Cyclical pain that stops her studying or working is not normal, and I say that out loud. Anti-inflammatories and hormonal contraception treat primary dysmenorrhea, but if there is dyspareunia or subfertility, I think endometriosis, and arrange a focused ultrasound on the sonographer's next visit, with a plan for what happens if that is inconclusive.
And the sudden one-sided pain that arrives with a known cyst, settles with analgesia, and no torsion is ever found. What happened, and what do you do?
Most likely a cyst accident, a hemorrhage or rupture, which is managed with analgesia and observation when she is stable, unlike torsion, which is surgery. But because I cannot fully separate them without a scan, my safety netting is explicit. Return immediately for worsening pain, vomiting or faintness, and I book the sonographer before she leaves, because the cyst that bled today is the cyst that torts next month.
Pull the whole morning together. What is the oral structure you would give the examiner?
3 buckets, said aloud in the first minute. The dangerous ectopic torsion, appendicitis, and the pregnancy test decides the road. The common, urinary infection, pelvic inflammatory disease, cyst accidents, and the contextual, her community, her confidentiality, her distance from services. Then I run the dangerous bucket first.
Now the fellowship lens. 60% of your mark is the content of your answers. Say the 3 sentences that score.
First, pregnancy test on every woman of reproductive age with abdominal pain, and a positive test with pain is ectopic until proven otherwise. Second, in the unstable woman with a positive test and free fluid, I activate theater and retrieval together, because the aircraft is 90 minutes and she may not have 90 minutes. Third, discharge is only complete when the follow-up has a named donor, the 48-hour HCG, the 3-month retest, the surgical review.
And the 40% that is style. What do candidates fumble?
They narrate uncertainty instead of structuring it, and they say organize without saying who, when, and how. The examiner wants to hear delegation with a name attached, the nurse doing hourly observations, the Aboriginal health worker arranging the community review, the registrar holding the phone.
Give me the signposting sentence you would open with if this were your exam station.
My name is Dr. Chen. I am the senior doctor in StAMPSville. This is a 24-year-old woman with acute lower abdominal pain and a positive pregnancy test. My priorities are: 1. Is she bleeding into her abdomen? 2. Is there a surgical clock running? 3. What can this hospital do tonight and what must move to the regional center? I will take the history in 90 seconds, examine, then give you my differential and plan.
That is an opening that buys you the next 8 minutes. Now the review segment. Last Saturday's child with fever and a non-blanching rash. First question, no thinking.
Assume meningococcal disease. Antibiotics within 60 minutes. Ceftriaxone 50 mg per kilogram intravenously, up to 2 grams, and I do not wait for the rash to evolve or the lumbar puncture.
Her blood pressure was normal on arrival. Reassuring?
The opposite. Children compensate, and a normal blood pressure is the compensation, not the comfort. Falling perfusion shows in the ridges first, cold peripheries, prolonged capillary refill, tachycardia. Hypotension in a child is a pre-arrest finding.
The retrieval call for that child. When?
At suspicion, in parallel with resuscitation, using a structured handover, not after stabilization, because stabilization without transport is a waiting room. And meningococcal disease is an urgent telephone notification to the health department within 24 hours, on the 1-300 number, day or night.
Close the loop on the household. What else belongs in the plan?
Clearance antibiotics for close contacts, public health coordinates that, vaccination status review for the household, and the equity point. The meningococcal B vaccine is funded for Aboriginal children, and making sure her siblings are actually immunized is the follow-up task that prevents the next case.
Final recap for today. 3 things to carry into tomorrow.
1. The pregnancy test is the first test in every young woman with abdominal pain, and pain out of proportion to bleeding is ectopic until proven otherwise. 2. Pelvic inflammatory disease is treated on clinical criteria before swabs return. Ceftriaxone, doxycycline, and metronidazole, with partners treated and a 3-month retest. 3. Ovarian torsion is surgery at suspicion, normal Doppler never excludes it, and an ovary that looks dead often is not.
And the thread underneath all three. In a town with no scanner tonight, no blood bank beyond 4 units, and an aircraft 90 minutes away, the skill the examiner is really testing is what you do in the first hour with your own hands, your team, and a telephone. D-82 tomorrow. We do this again.